Thank you, Yogesh. Yogesh has been my senior. It's such a pleasure to see you. And thank you, Dr. Rama, for having me
Hmm.
here. So, assessment of RV, are we doing it correct? Is my talk this time. Now, this is what the previous faculty was showing, looking at the heart surgeon's perspective. And as we see that the heart has this twisting motion, and the predominantly anterior part is the right ventricle, and the heart motions uh, 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 gives a very strange and very important anatomy. Understanding the right ventricle is situated just behind the sternum, and is a triangular shape,
In the
and it
meeting.
wraps around the LV cavity, which is a concentric shape.
I'll come.
Now, earlier RV has been an ignored chamber, but in 1616, way back, William Harvey described that RV may be made for the sake of transmitting blood through the lungs and not nourishing them. And we have now evolved over a period of time, understanding, looking at the RV by 2D, 3D, four dimension, vortex imaging, and lot. So, as we all know that RV is a highly trabeculated structure, has a moderated band. We identify the tricuspid valve, which is mostly apically displays, and it is very important to understand what are the leaflets, because Dr. Sanket was showing very beautiful images on 3D, and understanding the right side, looking at the tricuspid valve also by 3D is very important. But I would like to always mention that whenever we're doing 3D, we have to have an aorta perspective at 12 o'clock, and I will share you some good images. So RV has predominantly the superficial fibers, which are mostly circumferential oriented, and the deeper fibers are longitudinal arranged. So the in apical four-chamber view, the most predominant fibers are longitudinal, which are making around 80 to 90%, while the outflow tract has a circumferential orientation. Now, this is normally seen in a normal person, but it has been mentioned that in congenital heart disease, there is an additional middle layer of circular fibers, which has been demonstrated in patients of TOF, suggesting that there is an alteration in basic myocardial fiber architecture of RV, which can change and cause differences in the RV shape frequently seen in these patients. And changes in this myofiber and connective tissue architecture has also been demonstrated in some patients of tricuspid atresia. However, how to deal with it, with this alteration, in deformation parameters is still area of concern, and we are still learning the normal parameters of assessment of RV. But remember that in future, this middle layer of circular fibers may gain some interest. Now, these are very high-end images showing that the RV fibers are in continuation with the LV fibers. These are high-end MRI images showing that this is a single spectrum of muscle fibers which are in continuity. Now, why do you need an RV assessment? Because a normal ejection fraction of RV is around 40%, and it has been seen that if there is RV dysfunction in patients, it can have prognosticate information. So it is very important to have an RV function assessment, and the normal RV is quantified by around 40% to 75%. Understanding that MRI is still the very accurate method in looking at the RV ejection fraction. Now, why RV assessment? Because, as I said, it is one of the most important determinant in patient in congenital heart disease in patients who are presenting with pulmonary arterial hypertension, and does have prognosticate importance. This is some data showing patients who have high PA pressures with low RV function who do poorer as compared to those who are normal. You can look at RV, start looking, and you can have interesting images in patients of PUO, some masses, you can have RV myxoma. So the guidelines which came up in JACE looking at the RV showed that RV is an important structure. It pumps the same amount of blood as LV, but only using around 20 to 25% of the stroke work because it is pumping against a low resistance structure. And there are various RV echo measurements. We can look at dimensions, fractional area change, TAPSE, eccentric index, TR velocities, tie index, TDI, strain analysis, and 3D echo. But the most important is looking at the RV by looking at the dimensions. Remember, it changes with age. You have a lot of changes with congenital. So we still are now recommending that if you can index it to body surface area, and you can have the base, mid, and longitudinal axis, and the RV outflow tract measurements at all the levels. The fractional area change is being taken with, we have stopped using it much because we have now robust 3D data. But the most important is looking at the TAPSE, which is the tricuspid and annular peak systolic excursion, correlates pretty well with the ejection fraction. And any cutoff around 9.5 holds pretty good. If you have anything less than 9.5 in a patient of any cardiac problem, you're dealing with RV systolic dysfunction. So remember, TAPSE assesses your longitudinal function, because RV also acts as a piston and the contraction goes from base to apex. So the apex is moving very less. It is the base which is moving towards the apex. And you can look at the eccentricity index. Very important in congenital assessment is looking at the pulmonary acceleration time by looking any cutoff value of less than 100 milliseconds indicates raised PA pressures. And this is the way we do it in a patient, an 8-year-old patient whose PAT was around 55, indicating that this is dealing with pulmonary arterial hypertension. Also, you can also look at the systolic diastolic ratio. In this patient, it was around 1.9. This is the way we do it. And anything more than 1.4 indicates pulmonary arterial hypertension. Uh, to cover tie index, we don't do it routinely, but remember the tie index values are around 0.28. But rather, there are more information. Now we have started looking at the RV strain. Earlier data was looking at both the strains, both the lateral wall and the septal wall, but now a left ventricle takes care of the septum, and septum is no more being regarded. So what we do is lateral strain, and anything less than minus 20 is a normal thing. And this is a RV free wall strain in an operated case of TOF. You can see the strain was around minus 16.9, and this is the post-systolic wave, which also indicates some evidence of RV dysfunction. A patient of TGA who underwent a arterial switch in childhood, the strain of the right side was around minus 16. Again, the left side was compensating in this patient. A patient of RV of hyperplastic heart, looking at the strain, and as you can see, the left heart strain was around minus 3.8. So this is very important, focusing that you should only look at the RV free wall strain. You can also look at the hepatic veins. We know all about the RA assessment. I'm just going very fast because I want to show you that RV systolic pressures can be looked at the TR velocity jet. This is how we do in a case of VSD, looking at the left, the arterial LV pressures. You can look at the RV pressures also, looking at the gradient. Remember, parameter E by E prime of more than 6 on the right side can give you a rough idea of RA pressure of more than 10. And these are invasive data which are being compared. You can always also look at something as the pulmonary arterial mean pressure and pulmonary arterial diastolic pressure by looking at the PR velocities and looking at both the values. A rough estimate on non-invasive understanding of pulmonary vascular resistance is looking at the PVR by 10 into tricuspid velocity divided by VTI at the RVOT, and this is how we do it. Correlates pretty well with pulmonary vascular resistance, and the correlation is pretty reasonable. Now, don't stop here. Please start looking at the 3D images. You can get the RV volumes on a multi-slice 3D. We have been doing extensively. I just want to add that it is very important whenever we are doing a 3D is look at the aorta. Aorta should be put at the 12 o'clock, and you can get the transesophageal normal values in a patient of any congenital heart disease, as Dr. Shah was telling about the ENFAS view and the biplane view. And I would like to show you some few interesting pictures. This is a rheumatic heart in a young 12-year-old looking at the right-sided rheumatic valve, and 3D TE can demonstrate and you can planimate So this is the aorta, this is the septal leaflet, this is the posterior leaflet, this is the anterior leaflet. It is so easy to look at the tricuspid valve. You can also look at the valvular PS. Just go NFAS on the 3D, and you can planimate valvular thing, looking at the RVOT views. So 3D has now becomes very important. Now I would like to tell you, this is from Roberto's paper. Roberto is a very close friend, and we have been working a lot together. That the tricuspid valve has what happened? Uh, I think I will just again share it. I think once I just have two three images, and then I think I'll be through. The presentation got stopped. So what I wanted to tell is that just I have one or two images more. Then I think I will be done.
I think
Yeah,
it got stopped automatically, so you can
yeah.
just
I
try
think
to
these are
adjust.
big images. That's why the lap. I need maybe want to like to have one more laptop. So I'm just starting up. So the point is, we have to start incorporating the 3D data sets, and so yeah, I'm there. One second, I'm just sharing the data. We have started looking at the three leaflets of the tricuspid valve. Now, this is on TE. It is can be done. I mean, we got a very good overview. This is septal leaflet. This is the posterior leaflet. This is the anterior leaflet. You can three leaflets of the T from the ventricular perspective. You can also look at the RV, look at the tricuspid valve, and demonstrate more than three leaflets on a TE in a patient, because this is very important to identify. A very interesting things we have never been able to do is looking at the subvalvular apparatus on the right side. And this I got from one of my friends in who is in Japan, that you can look at the anterior papillary muscle, medial papillary muscles, and this can be demonstrated by 3D. You can look at the subvalvular apparatus. If you demonstrate this in tricuspid rheumatic stenosis, it generally confirms rheumatic valve. Subvalvular apparatus can also be seen on the transgastric view very clearly. This is a normal annular tricuspid regurgitation in a functional status, and I will show you a couple of more data. So this is how we start looking at the functional tricuspid regurgitation. This is the data things. You can also look at Barlow's valve on the tricuspid size. I don't know why the images are not moving, but
Shantanu,
it,
I'm sorry to interrupt, but you'll have to
I'm
finish it
done.
first.
So what I want to tell you is that looking at the RV is an important, but most important thing now is that we have started looking on the RV as a vortices. So remember, the RV vortices are very minimal, and this is the future. Any alteration vortices indicates there is the RV is not functioning well. So understanding the geometry and structure of RV is important, and RV function assessment should be done routinely in a detailed format. Thank you so much.